Welcome to episode 5 of series 4 of Diabetes Health Matters. My name is Dr Joan St John. I'm the host of Diabetes Health Matters, and I'm delighted to welcome you to this next series of 3 episodes. Diabetes Health Matters is sponsored by Eli Lilly and Company and Menarini, although they have no input into the content of the webinar series. So, in episode 5, we are going to be talking about the menopause, the intersection of menopause, those hormone changes, with diabetes, and also bringing in aspects of racialized communities and how all of these things intersect. I'm very excited because we've got such a wonderful series. We're going to thread through episode 5, 6 and 7. We're going to bring you information about the menopause in this episode, but this time next week, building on our previous episode on lifestyle medicine, we'll be telling you, using those pillars, remember from the lifestyle medicine episode, about what you can do if you're living with diabetes, living through the menopause. So stay tuned. This time next week, we'll be giving you some information about that. And then in episode 7, we're going to talk about polycystic ovarian syndrome and contraception. So it's like a thread that's going to thread through these episodes. Let's talk about this episode, episode 5, the menopause, how that landscape of symptoms looks when you're talking about the intersection and the changes that can occur with diabetes, the different types of diabetes, and how it is affected by those hormone changes which occur. Now, could we have any more fantastic speakers? We have 2 phenomenal speakers, 2 phenomenal experts. They are both award-winning, multi-award-winning advocates for health equity, for women's health, for hormone health. One is a media doctor. One is a doctor who has set up a specific bespoke service through her own experience of experiencing some of these symptoms related to hormones, that she has set up her own specialised bespoke service for women and dealing with hormones and health. They are phenomenal ladies. We have Dr Itunu Johnson-Sogbetun, who is a general practitioner with specialist interests in women's health and menopause care more specifically. She's also a tutor of GPs. She's a member of the British Menopause Society, and she's a passionate advocate for women's health equity. And she founded an organisation called Health Equity and Advocacy Learning, specifically for the Black population. Through her clinical work, her teaching and advocacy, she's committed to delivering high quality and personalised care to women at every stage of their life. And our other expert is Dr Aziza Sesay, who's also a GP educator, an Honorary Senior Clinical Lecturer, a host, a speaker, and a media doctor. You may have seen her on the red couch on Breakfast TV. She also helps health education, awareness and advocacy and empowerment through her platform, Talks with Dr Sesay. This platform shares evidence-based health information with a particular focus on women's health, cancer awareness, mental health, and health inequity. So, what phenomenal, I use the word again, phenomenal experts we've got. Stay tuned, stay active in the chat, ask lots and lots of questions, as I know you'll have lots and lots of questions. Today, we're specifically going to focus on the menopause, and then we'll give you some more information about what you can do about it. So we're going to hand over to Dr Aziza Sesay, who's going to start us off telling us about the menopause and diabetes. So welcome, Dr Sesay.
Hi, thank you so much for having me. I'm so excited to be here. So, in order for us to understand menopause and diabetes, we need to understand what exactly menopause is. So, in a really brief overview, here's a picture that shows what happens during our life stages, basically. So, at the very start, our reproductive years, we have what's called organized chaos. That's what I often say because people often talk about, oh, we need to balance hormones, balancing hormones. No, our hormones are usually doing this up and down thing in a regulated fashion, organized chaos. So we have our estrogen going up at certain stages of the cycle, and then it comes down similarly with progesterone, and we also have testosterone as part of it. Yes, we also release the male sex hormone testosterone. So that's quite organized in our reproductive years. Now we go on to the next stage that we call perimenopause. Peri meaning around the menopause. And this stage can be quite chaotic and it's not organized at all. We get the hormones doing its own thing. It's going up and down, but gradually they're declining. And during that period, you're getting a multitude of different symptoms that are happening. And the reason being, I think it's important to just stress here that often we think about estrogen, progesterone, and testosterone categorized as sex hormones. So you think of it just as sex, but actually we have receptors that respond to these hormones all over our body. If we talk about estrogen specifically, we have the receptors on our hair. And this is where when it starts to decline, we get the hair loss, the scalp changes. Similarly, we have receptors in our eyes, receptors on our skin, and so on. I wanted to stress that because it will then link to why we then get the symptoms associated with the perimenopause and the menopause. All right. I want to stress here that perimenopause can happen anytime from the late 30s, to the sort of 50s sort of areas, right? And it's particularly important that we know this specifically for Black women and even South Asian women. We tend to get these symptoms happening quite early on. So it's important that we don't dismiss symptoms when they're happening in the late 30s because essentially it can happen during that time. Now, we may notice changes to our periods, we may notice changes to our sleep, our mood, and so on and so forth, but we'll talk about the symptoms in a bit. That is perimenopause. It can usually last between 4 to 8 to even 10 years. And for some people, it can be really dramatic, and it can really affect their day-to-day activities in their lives. And for others, they don't really notice a change at all. So it's important that we're aware that one size doesn't fit all, and it can be very subjective, but it can also be very, very difficult for a lot of women experiencing it. Then we move on to post-menopause. So this is the time after menopause. Now, menopause is a period where we have not had a period at all. So we haven't had our monthly bleeds or regular bleeds for a full year. So it's what we call a retrospective statement. You've reached menopause if you've not had a period for 12 consecutive months, natural menopause, that is, right? The day after that is postmenopause. So we usually lump everything as menopause together, but actually the definition of menopause is just that. The day that you haven't had a period for 12 consecutive months, and then after that, the day after that is postmenopause. Postmenopause is a duration where you get the estrogen, progesterone, and the testosterone levels have dropped. Not completely, because we actually release some of these hormones from our fat cells and our adrenal glands. So it's not completely lost, but there is a massive decline in those hormones, and that's then what causes the symptoms. I want to stress here that we live 30% of our lives in postmenopause. So it is not the end of our lives when we reach menopause. And in fact, it's such a significant part. We need to nurture that stage because 30% of our lives is a long time.
Yeah, absolutely.
So menopause usually happens, the average age in the UK is 51, but we will stress and explain that it can be different for different ethnicities.
Amazing. Thanks so much. I mean, thanks for taking us through the different stages of our sort of hormonal life, really, and how menopause is what you've called a retrospective diagnosis. You have to look back. You have to see that you haven't had that period for a year to understand that the person is now in the menopause. Dr. Itunu, welcome. Anything you wanted to add?
It's just so important to understand that during the perimenopause, it can be incredibly chaotic, and it changes from literally all the time. Your hormones are changing, which is what makes blood tests in this phase very difficult. Because as you can see with the hormones, you can take a blood test and it looks like your reproductive years, or you could take a blood test and it looks like postmenopause. So if that's why for a lot of people, they're like, I want a blood test to let me know whether I'm in perimenopause or not. But a lot of the time we are not able to achieve that with a blood test. And if you have a normal blood test, it doesn't mean that you're not perimenopausal. So often it's a clinical diagnosis. But of course, in people under the age of 45, which is defined as early menopause, we would do blood tests, that is recommended by NICE that we do blood tests. But as I say, even if those blood tests are normal, it doesn't mean you're not perimenopausal. But why do we do blood tests? Because in that age group, if we confirm menopause before the age of 45, that has got really important ramifications for future health, and particularly for our diabetes cohort. So there's increased risk of heart disease, increased risk of dementia, increased risk of bone density loss, and other metabolic health problems. So with a lot of our patients with diabetes already have increased risk of some of these problems anyways. So if you then add early menopause to that, that is a significant metabolic shift problem. And so early menopause, so menopause under the age of 45, and premature ovarian insufficiency, that's menopause under the age of 40, is really important to pick up, because in these cohorts of patients, we would strongly recommend hormone replacement therapy to try and avoid some of these complications. But we'll talk about that later.
Where are we going to next? Because there is so much information there already. So where are we going next?
So what we wanted to talk about is some of the symptoms that you can experience during the perimenopause and the menopausal stage. So as we mentioned, you get the drop in the estrogen levels, and that's where you can get symptoms of hot flushes, mood swings, changes in the skin, and also the changes in your bone. Because as I mentioned, estrogen, the receptors are everywhere, and actually within the bone, it helps with what we call bone remodeling. So it helps to strengthen the bone. And that's actually why after menopause, so just like Dr. Itunu was talking about, we have the cardiovascular risk, but we also have the risk in our bone health. We're at higher risk of a condition called osteoporosis, which is where the bones become porous. It's like almost like they have more holes. They're not as strong. So we're at increased risk of fractures, which then increases our risk of accidents, and it's associated with death if we think about osteoporosis. So it's important that we're aware that those are potential symptoms that we get because of the drop in estrogen. Now, if we look at progesterone specifically, when it declines, that's when we get the irregular periods and the disrupted sleep patterns. Specifically, we're talking about perimenopause here, where you're getting the disruption in your periods and you're like, what's going on? What's changed? Why is this happening? And then we get the disrupted sleep patterns, and that can happen in the postmenopause as well. We also notice the testosterone levels lower. So this is where we may notice that we're getting quite low energy levels. Our muscle tone isn't as strong. Doing the muscle strengthening exercises are really important at this stage, because that helps to boost our testosterone levels, which then helps to reverse some of the symptoms that are associated. And then we notice the change in the libido, or essentially the lack of libido in that stage because of the drop in the testosterone. And then we look at the changes that happens within the other hormones. So we get the spike in the cortisol. Like with all of these symptoms happening, that will cause stress. And then when we get stress, that then causes a spike in the cortisols. And then we get a slower metabolism due to the shifts in the insulin and also the drop in the estrogen and the distribution of fat around. So we get the abdominal distribution of fat. So if you remember, and I often talk about this because it can make a lot of women feel a bit insecure about themselves, or like, why is my body changing so much? And it's not to do with them, it's to do with the hormonal changes that's happening. Specifically, if we think about the hourglass figure that, we tend to have and we attain, or society says that we should have. When we're going through the perimenopause and the menopause, the fat distribution changes, and then we have more abdominal fat. So you get the loss of that curve, and it's not your fault. It is, again, because of the fat redistribution, and also it becomes harder for us to lose weight because of that slowing down of our metabolism. And then we get the additional symptoms, which I'm not going to say are not as important. And in fact, it's important that we stress this one: vaginal dryness, or we talk about vaginal atrophy. So you get the thinning of the vaginal walls. Again, all of this is due to the drop in especially estrogen levels. They may notice painful sex, painful intercourse, itching and irritation in the area. There's something called genitourinary syndrome of menopause because of the drop, and it can cause really significant symptoms. And then they may have recurring, what we call UTIs, urinary tract infections. You may notice symptoms of palpitations where your heart is racing. You get the joints, aches and pains because of the changes that I mentioned earlier in the bone. Brain fog is so important because this is a symptom that I see so many times with patients coming in really worried that they have early dementia, when it is not dementia. It is literally because of that drop in the estrogen. And there's a lot of studies that's being done and research coming out that's linking that drop that then causes the brain fog. So brain fog meaning that you're finding it difficult to remember things, to find your words. You used to be a person who could just reel off all of this information, and then all of a sudden you get stuck even remembering your co-host name. And that can be quite scary. So it's important to recognize that as a symptom, because not many people talk about it. And also the mental health impact, the mental health load of menopause, the effects of the heightened anxiety that you can get with menopause. Just really quickly talk about a symptom that nobody really speaks about as much. So my aunt, she stopped driving, and she didn't know what was going on for the longest time. And then when we go back, it's because that was part of her perimenopausal symptoms. She had the fear of driving, and that is a symptom that's associated with menopause. But I know I've said a lot, and I'm sure Dr. Itunu probably wants to add a few more things.
I mean, you've covered it so well. I mean, I think what I was going to say is that there are over 75 symptoms of perimenopause and the menopause. So there's so many different things that women get during this time. We've mentioned some of the big hitters, but I think it's important to recognize that if you're noticing any changes in your body and you're not sure, you can speak to a healthcare professional. And I think it's also important to recognize that with different ethnicities, different symptoms tend to be more prominent. So for example, with Black people, we know that vasomotor symptoms, so the hot flushes and night sweats, are very prominent and can even last up to 10 years. And that's quite a longer average than for our Caucasian counterparts. We also know that as Black people, we carry a lot of allostatic load, especially as Black women. We are under a lot of pressure. So the cortisol shifts can really impact our symptoms even more. And to say this about the weight gain, if you do nothing, so you're eating the same, you're exercising the same, you are likely to gain 0.5 kilos per year during the perimenopause. And that weight is generally going to go around your abdomen. Now, of course, with rising stress levels, cortisol, allostatic load, minority stress, all the different things, midlife stress, where we're often looking after two generations, the young, the old, the vulnerable, that means a lot of the time that stress level is more, or we might even be eating more to manage our stress. And so you can gain sometimes even up to 1.5 kilos per year. And so, this is really, really a big issue, particularly for women with diabetes or pre-diabetes, because this could be the thing that moves you from pre-diabetes to diabetes, or worsens your insulin resistance and takes you from type 2 diabetes or medication, or oral medication, to needing insulin or other medication. So it's so important because of the impact. And of course, the symptoms that we experience during the perimenopause and the menopause can be heightened by stress as well.
I just wanted to touch on what allostatic load is in case the audience aren't aware, if that's okay. So usually look at all of us on the screen and you think, oh, look at all these young looking Black women. They're no way over. Yes, even you, Dr. Joan. There's no way that they're, over 40 or so on. We're not. But basically what I'm saying is we often look younger for our age. And there's this saying, Black don't crack, right? But we do crack on the inside, and that's where the allostatic load comes from. So when we think about homeostasis, that's how our body is doing things when we are at rest, essentially, when we're not stressed and there's nothing else going on. Now, allostasis is where our body tries to maintain our stable state when we're stressed, okay? So I often use the analogy of we're riding a bike. Just imagine homeostasis is where you're riding a bike on a steady road. It's a lovely day and there's nothing going on. Allostasis is where you're riding the bike and it's raining and there's blistering, there's wind. It's like, and you're having to hold on to the handles and you're pushing. So your body is having to fight really hard, raise blood pressure, your heart's racing, and your muscles are tensing. All of those changes happening in order to try and keep that stability. Now, what happens in Black women is we're dealing with that all the time. So where our normal, our stable is supposed to be here, we're constantly at this stage. We're constantly being exposed to that cortisol and all of the symptoms that are associated, which in the long term has an impact on our cardiovascular health, then has an impact on our body's ability to maintain and metabolize sugar and so on and so forth. And that's what then tips us over the edge. And I think it's really important that we do talk about this, particularly as women of color, especially in this day and age where things are very, very difficult, and how that in itself impacts our health overall.
Amazing. I was going to say that the 75 symptoms that you outlined, that's quite astonishing really when you think about it. But even for women who don't experience a lot of the symptoms, certainly the change in body shape, the increase in weight tends to be a very common thing that women will encounter during this time of hormone changes. So there's so much we're going to talk about, and I know there's going to be lots of questions, and I'm hoping everybody's going to be really active in the chat as well. So tell us about these falling estrogen and rising resistance levels. What happens there?
Right. So I think it's important to understand that as our estrogen falls, because of all the things that we've talked about, there's a metabolic change in the body, and it reduces insulin sensitivity and increases insulin resistance. And then with this weight redistribution that we've talked about, and also counteracting muscle loss, which happens in the menopause. So we've talked about bone density loss, but muscle loss also happens as we get older. And so all of that means that the body is struggling to use glucose as effectively. And that means that insulin is working harder, and we get insulin resistance, which increases the risk of type 2 diabetes. And so that means that, with the hormonal changes, we are at increased risk, if you've already got diabetes, of getting poorer control. So you might suddenly think, why is my HbA1c rising? And it could be as a result of this. But also, if you are pre-diabetic, it could be that thing that tips you over the edge. Now, we know already that Black women are 3 times more likely to have diabetes anyways. And so we are at increased risk of this compared to our counterparts, in addition to South Asian women. So this is a really important thing, and it should help us understand what's happening in our bodies, and that should help us understand how we can counteract it, because obviously this is a change. It's difficult, but are there things that we can do to resist this change, to make our diabetes management better, or to reduce our chances from going up from pre-diabetes to diabetes? And of course, if you have type 1 diabetes, if you have reduced insulin sensitivity, you might find that you're requiring higher doses of your insulin to be able to manage your symptoms. So for everybody who has diabetes, whether you're type 1, type 2, or pre-diabetic, you might notice a change. And so what can we do? And we're going to talk about that in a little while.
Hugely important. The fall in the estrogen levels is causing that increase in insulin resistance. And so even if you do the same things that you were doing before, even if you're living your most healthy life, the impact on your blood glucose is going to be different. And so many women find this, experience this, and just can't understand why it's happening. So thank you so much for outlining it so clearly, Dr. Itunu.
Thank you so much. Now, the vicious cycle of symptoms and sugar. So as you can see, Dr. Aziza and I are very, very passionate about the biopsychosocial, because we do not exist in silos. We are actually very complex individuals as women, right? And as Black women. So with menopause, one of the symptoms we talked about was the sleep disruption. And of course, you can get night sweats. And we mentioned that for Black women, the hot flushes and night sweats can be worse. And that can further add to the sleep disruption. And that can worsen sugar control. And that's because sleep is really important for our metabolic regulation. Now, that, of course, can impact our stress and our mood. And we know that, again, the menopause in itself can impact our stress and our mood. And so that cortisol then rises, increasing blood sugar. Then you can get physiological spikes because of the hot flushes. And then high sugar can then cause you to feel more vulnerable. We talked about some of the genital urinary syndrome of the menopause. You can get more symptoms vaginally, more vaginal sort of infections, more urinary tract infections and things like that. And then that again can make things worse. So it can be a very vicious cycle, bringing everything into play. Aziza, I don't know if you want to say anything about this.
No, I think what I want to just add here is the importance of self-compassion.
Absolutely.
Because we've mentioned a lot about how a lot of these things are beyond our control. And personally, if I share, I've noticed, I'm going to be 40 this year. I've noticed a shift in, I'm eating the same as before. And my weight isn't doing the same as it used to do. So I'm personally noticing this, and I'm having to give myself grace about it, but I'm also taking action. So it's about being aware, giving ourselves grace, but also being intentional, which we're going to talk about in terms of what we can do to help to stop this this vicious cycle.
Absolutely. I mean, I can relate because I'm also, close to that age. And I've been getting night sweats. My sleep has been impacted, and you can already see, literally having to work a bit harder anyways. And I already live with PCOS, which is another hormonal issue that we're going to talk about at a later time.
Dr. Sesay, you use the analogy of trying to keep the bike going, and this I see as the rain and the wind and the bumpy road and the potholes, just trying to keep on track whilst all of these things are affecting your life. Thanks very much, Dr. Itunu.
Absolutely. And then when you then think the allostatic load on top of that, existing in spaces that weren't necessarily created for you, for those of us that live in the Western Hemisphere. And so it's just a lot to contend with.
Be compassionate with yourself.
You have to be so kind to yourself. Now, I think it's important to realize that this is a one size does not fit all. We already talked about how the symptoms and the metabolic changes with the menopause for type 1 diabetes can specifically increase insulin needs. And in type 2 diabetes, insulin resistance often worsens, and that might require medication adjustment. So oral medications, you might need to add in a GLP-1, you might need to add in insulin depending on what happens. But of course, there's stuff that we can do to try and fight back, and we'll talk about that in a minute. And then the pre-diabetes, as I said, hormonal shifts can just be that tipping point. And so this is just to demonstrate that. We've already spoken about this. Now, Dr. Aziza, do you want to talk about the differences? We've mentioned a little bit of it, but do you want to talk a little bit about the differences that Black women have with the menopause?
Absolutely. I think we've already hinted that sadly, when it comes to menopause, it hits us pretty hard. And the truth is, we don't have enough research to understand why this is the case. There's so many suggestions as to why they're more likely. And we've spoken about the stress, the systemic racism, so on and so forth, that could be attributing, and also us entering menopause in the worst metabolic stage than other ethnicities. There is this one study, which I think is good to look at. It's a longitudinal study over 25 plus years and we've pulled a lot of the data from there, really, that because that's the limited evidence that we have so far. When we talk about menopause, the average age in which it happens, we say 51, but really it can happen much younger in Black women. And the reason we wanted to stress this point, so we say on average 49.3, but it can be even less than that, is because there's so many Black women who present to their GPs. And I love that Dr. Itunu mentioned about the blood test not being an indicator for diagnosing perimenopause, because it can still be it can still be outside of the range as normal, yet you have perimenopause. Do you understand? And then you have a lot of Black women who are then suffering with their symptoms because they're being told it's so unlikely, you're only 35, but it can happen, as in perimenopause can happen even in that age range. It's also important to be aware of the fact that it can go on for 10 years. Dr. Itunu mentioned this before. On average, we say it's about 6.5 years, but actually in Black women, it can go on for 10 years. And for many women, it improves over time, whereas in Black women, our symptoms seem to get worse the longer it is, if that makes sense. We are also 3 times more likely to experience premature menopause. So that's where you get menopause under the age of 40. Now, natural menopause under the age of 40. There are many different reasons for this, but you can actually, if we think about Black women and we think about hysterectomy, which is where we get the removal of the womb, it's important that we talk about the fact that for several years, we were more likely to have hysterectomies. And the reason being is we're more likely to have conditions like fibroids. So fibroids is where you get, I usually have my props and I'm always showing, but it's where you get growths, benign growths in and around the womb. So this is the womb, ovaries, fallopian tube, cervix, and vagina, but you have growths, benign growths, benign, no, we don't like using that words, but essentially non-cancerous growths. The reason we don't like using the word is benign sounds like it's harmless, but actually can cause really debilitating, significant symptoms. But that's for another day. Happy to talk about that at some point. Essentially, the cure for fibroids is removing the womb. We're more likely to have conditions like adenomyosis and so on and so forth. So when we have the womb removal, you're essentially plunged into menopause earlier. You're more likely to go into menopause earlier, which again is associated with the significant symptoms and the difficulty. And then we also have the BMI paradox, which is that Black women we are more likely to develop the diabetes, 3 times more likely, and we're more likely to develop it at a lower BMI than other groups. Now, depending on who you're talking to about BMI, we already know that essentially BMI measure is not very accurate for ethnicities outside of the Caucasian or the Eurocentric ethnicity. So that's probably playing a part as to why we're developing it at a lower BMI. But I'll let Dr. Itunu continue here.
Yeah, so the thing about the BMI is that we actually don't have a really good way of estimating our sort of weight health risk because, as we know, our body shapes are different on the whole to Caucasians. Even our kind of muscle mass build can be different, and so we use BMI because it's the language that we use medically, but we use it with a pinch of salt. That's how I describe it, because we are aware that it's not the best marker. But a lot of medications, the dosage, the guidelines are all put in BMI. So that's why we use it, but with a pinch of salt in our Black and Southeast Asian communities, being aware that, again, we are using rules that were not necessarily created for us. And this speaks to the wider landscape where there's not enough research, not enough directed guidelines for us as Black people, and so much more is needed, and so much more it needs to be done. And just talking about the data gap, so we see this age of 48-49 as the sort of average age of menopause in Black women, but this is the average data that we see in Black women living. So this data comes from African American women in America. We've seen similar in the UK, but we need far more research in the UK. What we estimate is sort of similar, 48-49 in the UK, and also in urban areas in Africa, particularly areas where people are living more of a Western lifestyle. Now, there are not many studies, but for the few that I've managed to look into in rural parts of Africa, you see a slightly different average, which might be a little bit later. And I wonder if this, I mean, obviously we don't have the evidence, but I just wonder, when I've had a deep dive into the data, because if you know me, you know that I'm really passionate about menopause in Black women. So I wonder if there is a gap there's a lifestyle gap, and the more we're under stress, the more the epigenetic changes, the more that we are living under this allostatic load, perhaps it's pulling that average age of menopause earlier. And so that's something that, as I say, we don't have evidence for, but anecdotally and just looking into the data gap, the limited data gap, I think that's something we need to question.
Fascinating. And I would just add 2 points. BMI, we always describe as quite a blunt tool on this series of webinars. And it can be made more sophisticated, let's put it that way, by using things like the waist circumference or the waist to height ratio. So that is one way that you can make it more discerning as opposed to that blunt tool. And we know that for people of African Caribbean heritage and origin, that the BMI of about 27.5 is what we're aiming to keep it below that in terms of health.
Thank you so much, Dr. Joan. Now, we've talked a lot about the cultural barriers, but I think it's important to just put it down for you to see the images. Now, I think the most important challenge that we have is this perception of Black women as strong, the strong Black woman, and expectations that we should endure silently, we shouldn't complain. And many of us buy into it, suffering and smiling, and we wear it with pride. But really, we shouldn't, because it's impacting our physical and mental health. There is strength in admitting I'm not okay. There is strength in seeking help. There is strength in saying this is difficult. That is strong. That is strong too. Because, a lot of this perception has come and is pushed on us. And we are expected to be the burden bearers for society, and burden bearers for our community. And sometimes it's just too much. Now, of course, there's also stigma and taboo that happens in the menopause. And in some of our subcultures in Africa, we know that menopause can be seen as a loss of sexuality, of femininity. And as a result of that, some women are afraid of even using that word because they don't want to be sidelined. We know that some women fear that that their partner might get a new partner, a new younger partner, and it happens, a second wife or a girlfriend or something, and they feel that fear. Some women, who, and this is really important, I think, as well. I often talk about the unexpected singleness. So women in our community who would have liked to be in a relationship but have never managed to find the right partner, and there's a lot of societal pressure to have gotten into a relationship, to have children, and when they're told you're menopausal and that fertility loss, it hits them like a slap in the face, and again, that can be heartbreaking for women. And that pressure can be a lot, and that with everything else that we've spoken about again. So you can see how there's so many layers of stigma and taboo and cultural challenges that can be faced by Black women going through this, the menopause. Then we now talk about the systemic factors, and of course we've mentioned about medical racism, we've mentioned about difficulty with accessing the care that people need. But it's so important, because a lot of the time Black women feel like when they go to see the healthcare professional, they might be feeling sort of medically gaslit. They come with their concerns and they're told, oh, no, it can't be. Or the heavy mental load, which we've talked about as well. But the system wasn't necessarily created for us, and we almost have to carve our way through, find a light through. And that makes it even harder. We're struggling, but we have to find help for ourselves. We don't immediately get help if we reach out. So even deciding to get help can be a challenge, and then when we reach out for help, we might not get the help that we need. And so this is where it's so important about culturally competent care, and we'll be talking about it. But the result is that often people feel like symptoms are dismissed or normalized, and then people feel like they don't want to seek help because they may have tried or they may have had previous bad experiences. Aziza, I don't know if there's anything you want to add here.
Yeah. Oh, wow. Thank you so much for sharing all of that so passionately. And this is exactly why we share a lot of information online or through Zoom and through community talks, because one thing that I really stress is the fact that there's a lot of stigma and shame and taboo around these sort of topics. And we talk about anything women's health, all of a sudden people shy away because there's the hypersexualizations of our bodies. And I often carry around little props on purpose to try and destigmatize and remove the shame associated, because you have a lot of women within the community. Yes, there's this the stigma associated with the lack of fertility, but there's this stigma associated with talking about periods at all. I remember when I asked my mom, what sort of age do you think you reach menopause? And she said, well, what's that? What do you mean? I don't understand. Or what symptoms did you have for menopause? She's like, no, I didn't have anything. She did have symptoms. She had the psychological symptoms, the mental health symptoms, but she didn't attribute that. And she wasn't aware that those were associated with the menopause. And again, stigma that's associated with psychological symptoms, mental health within our communities. We don't talk about it. So it's important that we have these discussions, that we have the education around what menopause can present with and the symptoms that are associated with menopause. And let's not normalize the symptoms associated with menopause, because I do have a lot of people within my community who say things like, well, our grandmothers and our mothers went through it and they were fine. Let's not make it such a big deal. It's not a big deal, but it's because of that strong Black woman narrative that we've had for such a long time that is being perpetuated and being passed down. But I think that our generation is hopefully going to nip that in the bud, because ultimately these symptoms can have a significant impact on our long-term life. And if we don't, early intervention, I always say early detection saves lives, but early intervention is most important. Yes, let's catch it early, but what are we going to do with that information? How are we going to change things to improve our long-term health?
So I think we have really broken the silence on these topics of hormonal health throughout the ages of women, and looked at all the different aspects that can impact it. And we've spoken about so many things that can affect women in our society, well, as they go through and try and navigate these hormone changes. It has been an incredible discussion so far. And as always, we're about solutions. So we're about empowering, we're about sharing information and knowledge. So I'm asking that people come back to see the next episode, where we're going to give as many solutions, tips, advice as we possibly can to help you navigate this situation, this difficult situation at times, not for everybody, but how you can navigate it. So please come back and join us again for the next episode.
And a big thank you to Dr. Joan St John for this interview. We are now moving to the Q&A for those of you who can stay with us. There's quite a lot of us on the line this evening. We're also joined by Dr. Isioma. I can't see Dr. Isioma on the screen. Oh, there you go. Dr. Isioma Okolo, who's a consultant obstetrician and who has been listening very intently and carefully during this first segment, and who's ready to answer questions that you have. And I'm Greg Trax. I work with the Diabetes Africa team, and happy to moderate this Q&A. And shall we jump right in, Dr. Joan, Dr. Isioma?
Yep, let's go for it.
Dr. Isioma, I do have a sort of an opening question for you. And in your clinical work, how often do you see menopause intersecting with diabetes? And is that connection something women usually recognize themselves?
Yeah, thank you for that question. So I do see it a reasonable amount, and I think it's perhaps because of the caseload I look after. So I think about a third of my caseload is postmenopausal, perimenopausal care. I run specialist clinics. And I guess if we think about the general population, I also am based in Scotland. Scotland has relatively higher levels of type 2 diabetes and obesity. But because of that, I think I'd probably say maybe about I'd say maybe 1 in 5 of the patients I look after have got diabetes. In my experience, what often happens is these patients have been referred from their specialists. So that's actually quite helpful. Taking a big step back as to where most women with diabetes would meet a gynecologist, it would be in a general clinic. So it might not be that, for example, they presented with a menopausal or perimenopausal issue. So that is how it can be maybe challenging to address if it's not come directly through that way.
Thank you. And are there particular patterns you tend to notice for women living with diabetes who enter perimenopause or menopause? Are there, whether in symptoms, glucose variability, or the way women experience their diabetes?
Yeah, so I think these symptoms and what you've just asked were covered brilliantly by Dr. Aziza and Dr. Itunu in their talk. So talking specifically as to how menopause shows up in patients with type 2 diabetes, but also the realization that actually patients with type 1 diabetes are more likely to go through menopause early. And that's threefold, really. There's an element of the increased association with autoimmune conditions. There's the increased, I guess, aging of the ovary because of the microvascular disease that goes on with diabetes. And again, this ovarian aging, and I guess the metabolic load that was described as well, and the chronicity of the disease. So with regards to the presentation, what's quite shocking, actually, this is quite an interesting statistic. 70% of women do not actually appreciate symptoms of the perimenopause and menopause. And most people think hot flushes is the commonest symptom, but actually commoner symptoms are, I would say, mood changes, sleep changes, and brain fog. But in our case, when people are referred specifically to our clinics, often what they are presenting with is the most concerning is vasomotor symptoms, so the hot flushes. But actually, there are other symptoms that are actually commoner. Dr. Aziza touched on a very important symptom, which people often, because of the shame and stigma, are not willing to share. So vaginal dryness and how that shows up, for example, with regards to painful intercourse, an increased risk of urinary tract infections, vaginal infections, or actually just the sensation of an infection. So this, where you don't have an infection, but because of the thinning of the vaginal skin, and also the background of, microvascular changes that are present in patients that have diabetes, that can then manifest as a cystitis, where you don't actually have an infection, but you feel like you have an infection. And actually, some people report going to health practitioners and being treated for UTIs over and over again, and actually what they needed was perhaps vaginal estrogen. Another way it presents, I think it's very important to talk about, is the mental health burden. Many ways. One, the actual brain fog, but also women are experiencing these symptoms at the point in their life where they are maybe perhaps meant to be at their peak. They have conflicting, roles with regards to their caring role, their professional role, but also I think particularly with women who have type 1 and type 2 diabetes, the body changes that occur that can also impact your insulin and your glucose control can be very troublesome, I guess, when you think about the impact on your mental health with regards to how you view your body, and in particular with how you view the body changes with regards to the change from, I think Dr. Aziza referred to it as, the kind of like figure eight shape to more central adiposity. What's actually important to also recognize is even without a change in weight, just this shift in, I guess, fat distribution, to this more central adiposity and this increased visceral fat, that in itself can impact people's insulin resistance and also diabetic control. So very important to realize it's not just the number on the scale, the shift in body composition is important as well.
Thank you, Dr. Isioma. Dr. John, did you want to add anything particularly around that intersection of menopause and diabetes and how often women do realize that this may be happening?
Yeah, I think the only thing I would add is that it's coming in our clinic from a different perspective. So in our clinic, it's when somebody is wondering why their blood glucose is not managed the same way that it used to be previously. And they're doing the same things, following the same patterns, lifestyle patterns, but somehow the glucose may be either spiking or dropping, or it may be a bit more high than it was previously. And then we're trying to fathom why that might be the case. And I mean, what was brought up very clearly in the episode is that during the perimenopause, these changes, these hormone changes may be going on. The changes in the blood glucose and the insulin resistance may be going on at a time when you're not even actually fully aware that this person is going through the perimenopause at that time. Do you see what I mean? So it's trying to understand that. And I think we're getting a better understanding of that now. I mean, there have been some questions about, how soon should we start adjusting treatment when we're thinking that this might be associated with hormone changes. But I think it's something that we have to monitor, something that we have to be fully aware of, and just keep an eye on, really, and work with the person to ensure that the blood glucose levels remain as good as they possibly can.
Thank you. And just also for the people in the room, just wanted to let you know that we are running some polls about this session. If you are on your desktop, the poll should have popped on your screen. If you are on your mobile, you may have to swipe left or right to see the polls. Do let us know about what you've learned, whether you've learned anything in this, anything new in this session, and also we've got some questions about future events. So we have quite a lot of questions. You mentioned, Dr. Isioma, briefly the stigma and shame, and Dr. Eva Jenga from Kenya, who's also with us tonight, said, I found that just giving a woman time to talk about her challenges, symptoms, and reassuring them that this is a real issue shouldn't be ignored or dismissed. It helps a lot. Did you want to react to that?
Yes, I absolutely agree. Unfortunately, women's health in general is just shrouded in shame, and the shame drives the silence, and then also, I guess people maybe delay in seeking, there's the lack of awareness, I guess, but then there's also delay in seeking help because of all these various things you've talked about. But there is the reality that we know that women are unfortunately frequently dismissed. And I think, Dr. Itunu used the phrase frequently gaslit by healthcare providers. So awareness is one thing, but also, unfortunately, many women feel like they have to advocate so strongly for themselves, especially Black women, especially ethnic minority women in these spaces. And that is a problem. And that's why having spaces like this and organizations like Diabetes Africa is so critical, so that people are armed with awareness. And, I love what Dr. Aziza said about being kind to yourself, but then acting. And part of that action is like the advocacy. And speaking about it, in the comments, I saw someone saying something about how perhaps we should be talking about this at a younger age with both boys and girls. Absolutely critical. Most of us in the room maybe can remember or maybe not remember what our sexual health education was like if you had any in school, right? And if you think about that statistic Dr. Aziza shared, specifically about the menopause, which was that we spend 30% of our life. But if you take a step back and think about the perimenopause, thinking it can happen, even in your late 30s, for some people, that will be almost 40-45% of their life. And, not all of us, most of us will not have diabetes, but all of us will go through the perimenopause and menopause if you live long enough. Okay, so this is I think it's the most important phase of a woman's life. And so the shame and the stigma, this is something we have to address head on.
Dr. Joan, each one teach one, right? And we've got a mixed audience as well this evening,
Yeah,
men and
absolutely.
women.
Absolutely. It has to be men and women. It can't,
Mm,
women don't exist in isolation. We
mm,
exist together. So it has to be men and women. And yes,
mm,
absolutely, each one teach one. It is so important for all of us to be informed about this. Women are spending a third of their life in this part of their life, the
mm.
phase of their life. So it's so important that everybody has understanding of it.
Hmm. Uh, Thank you, Rebecca. I see you've got your hand raised. Could you please put your question in the chat so we can answer it, or your comment? We've got some questions about medications. Are there any, just a general question, because we can't address specific questions, but in general, because we hear so much about GLP-1 at the moment, Dr. John, is there anything that's GLP-1 or other that women who are going through perimenopause or menopause should be cautious about? Are there any recommendations around medication when one is going through menopause?
Remember, we've said going through menopause is part of a woman's journey through life. So it isn't that a one size is going to fit all. Yes, everybody's talking about GLP-1s at the moment, but that doesn't mean it's the answer for everybody. It may be, and we've picked this up in the chat and the questions, it may be things like weight training, it may be things like resistance training, it may be changes to lifestyle that need to be made. It isn't necessarily the one type of medication which everybody's talking about at the moment. Although that may come into the picture. For some people, that may be the answer to the difficulties that they experience with things like weight management. So, yes, I can't say that one size is going to fit all. It is about that person-centered, individual conversation with their healthcare professional.
Mhm. Absolutely. The one thing I would add is that so there are like everybody's talking about GLP-1s, and for us as gynecologists, when you come into the specialist area, I guess with patients with diabetes, if they are on these medications, we often know, right? Because it's come in the GP letter. But the challenge we're having is patients who are accessing these drugs privately, which is not a problem if you think that's the best thing for you. That is the best thing for you. However, and us not knowing, and where it is important, I now know that in my clinical practice, 1 in 3 women who come to my clinic are on GLP-1s. That's a very high number. So I now routinely ask every single person coming in, even if you just came in for a smear that was difficult in practice, are you on these medications? Not because I'm nosy, but because I want to know so that I can safely prescribe medications for you that do not interact. So one thing I will say is, especially because we're talking about menopause, is if you are on these medications and you're on HRT, we now have guidance from the British Medical Society advising that if you are on HRT that has an oral element to the hormone called progestogen, to consider swapping to a form that is not taken orally. So this could be either a coil or a combined patch. So this is the key thing I would say, because as a gynecologist, then we run into challenges with perhaps HRT causing problems with interactions in these drugs.
Uh, uh, Thank you, Dr. Isioma. Dr. John, we have had some discussions in the chat about checking estrogen levels when a person is on HRT. Did you have any thoughts, particularly the role of GPs in checking estrogen levels?
Well, I think it was again brought out in the episode that you have to be very careful about who you're checking the hormone levels with, when you're checking the hormone levels with. It's not appropriate to check them for everybody. That's certainly the case. And this can be sometimes quite a difficult concept for people to accept, that checking it, if you remember those sort of, if I can put it like the wiggly lines that were shown at the beginning, if you check it at one point on that wiggly line, it may look as though everything is fine. If you check it on another, it may suggest that you are either perimenopausal or menopausal. And so that's why in primary care people are reluctant to do these tests, but there are certain specific circumstances where it can be helpful. So if people are using contraception whereby they don't have any periods, sometimes it can be helpful to check some of the hormone levels then, because that can give an indication of whether or not somebody's in the menopause. So there are very specific circumstances where it can be helpful. And as we brought out in the episode, when these symptoms are occurring at a very early age, so before the age of 40 or before the age of 45, it can sometimes be very helpful there as well. Isioma, did you want to add anything?
No, I would agree with you 100%. And I think sometimes checking can cause anxiety because of, those squiggly lines you described so perfectly. And I was just typing in the chat, we diagnose, menopause as 12 consecutive months without a period in the absence, of course, of pregnancy or use of birth control. So, it's a clinical diagnosis that there are very few situations where we then need to actually do the hormone testing. Of course, if you suspect this is somebody who has premature ovarian insufficiency, very early onset of menopause, that's a different kettle of fish. And then in our menopause specialist clinics, we very rarely check hormone levels when we are changing certain preparations of hormone replacement treatment. But that is very, very unique, not as common circumstances.
Thank you. And thank you also, Kerry, in the chat for sharing your lived experience and telling us what has worked for you. And that goes back to what Dr. Joan was saying about everyone having to find what can help them individually. There's a question here in the chat. Does regular breast pain is linked to menopause? Maybe not to answer this question specifically, because we could I feel like we could go through a lot of symptoms, a lot of questions around, is this menopause or not? How do you approach this more generally speaking, Dr. Isioma and Dr. Joan?
I generally say, it's interesting because Dr. Itunu said in her talk 75 symptoms, and I complete that sentence that we know of. I have a running joke with my friends. Anything in life, any problems we're having, the answer is perimenopause. And so if you have a problem in life, yeah, the answer is perimenopause or menopause. And breast pain is a symptom. So, with the menopause, perimenopause, we're talking about fluctuations in hormones. And actually, if you cast your mind back to maybe when you're having more regular periods and the changes some women experience. For example, breast tenderness or even like nausea and mood changes, appetite changes. And these changes, even before you're perimenopausal or actually postmenopausal are occurring because in your natural cycle, you are having these fluctuations, those squiggly lines. And so that is why these symptoms are happening. And there is almost no part of your body that does not have a receptor that responds to estrogen in particular, and of course progesterone. So yeah, everything could be the perimenopause or menopause.
Dr. Joan, anything to add? How do we approach this? How because it as we mentioned also it creates anxiety perhaps about these symptoms can make people anxious, and it adds to the load that we were talking about.
Awareness, I think, is one of the things. So the 75 symptoms that we know of, but also sometimes people used to call the menopause the change, didn't they? And I think that's one of the ways of knowing or suggesting for yourself this might be perimenopause or menopausal symptoms, a change in you, a change in what is your normal, a change that may be the periods, but it may be the brain fog that was spoken about. It may be the hot flushes. It may be nausea. It may be breast tenderness, but it's a change for you. So that is something that is a bit of a flag to say to you, maybe this is associated with perimenopause or the menopause.
Thank you. Rebecca is asking about a new diagnosis of type 1 diabetes that's accompanied by lots of symptoms. Could it be menopause? Have I entered menopause? What should be the normal approach that you would take in your practice?
So So not because I'm not Rebecca's healthcare professional. I'm going to talk in general, and I hope Rebecca that is acceptable to you. So we know that if you are living with type 1 diabetes, there is some evidence that menopause, perimenopause can happen at an earlier age. We have learned from the episode that for African Caribbean heritage women and South Asian women, that the menopause tends to occur at a younger age. So we are having intersections here of living with type 1 diabetes, a particular type of diabetes, being perhaps from a, a minority ethnic group, and the intersection of those two things may mean that you develop perimenopause or menopause at an earlier age. And so in those circumstances, it's certainly worthwhile having a conversation with your healthcare professional, and getting some checks done.
Dr. Isioma, what would be your advice?
I think my advice would be to have, an index of suspicion, but not to assume, So is it a hot flush or is it a hypo? And that's actually very important, because if you're used to responding to your hypos in a certain way, because oh, this is definitely a hypo, and perhaps you maybe don't check. What if it's not hypo? So I think we have to go back to basics. And yes, you have a list of things you think it might be, but what we want to rule out is the most serious and most harmful thing first. But also feeling brave to ask your provider, could this be the menopause, or could this be my diabetes? I think as well with regards to skin changes and, even like symptoms such as pains, limb pains, that can come with reduced bone density, muscle wasting, but also we need to be aware of, say with diabetes, peripheral vascular disease. So we can't assume it's one or the other. You should just have an index of suspicion and ask, could this be it? And another step for further in advocacy is, if it's not it, what else could it be? And what tests would you recommend to rule out something serious? I think this is something I share with women to ask providers in general.
Mm. And there were questions about approaching all of these changes that what you call the change, Dr. Joan. From this can be very overwhelming from a mental health perspective. What is your advice, Dr. Isioma? How do you approach this from a personal management perspective?
Yes, it is really overwhelming. We've heard about the mental health burden. We know that Black women, ethnic minority women, live highly contextualized lives. I think it boils down to giving yourself grace. And sometimes, some days, sometimes it's really overwhelming and you need to cry it out. You need to find your safe spaces, people you can talk to, trust. And then some days are for action, some days are for crying. We need to think about ways to look after ourselves individually, but also as community, whatever that looks like for you, what is appropriate in your own like cultural or individual context. We talk about managing stress. I am a big proponent of lifestyle medicine, but I know that for some people, lifestyle medicine doesn't make sense. How can I, with my conscience, say to somebody who's working 3 jobs to try and manage their stress or to sleep better and there's a single, it's really hard. So we need, as a provider, what I need to know is more about my patient's, I guess, social context. And I encourage people to explore what better sleep or stress management looks like for them, or even exercise. We talk about walking and going to the gym, but for some people, the gym doesn't make sense. It's not appropriate. What about, with regards to when you do your shopping, how much and how many bags are you carrying? How far can you walk with the shopping? So it's about taking a personalized and holistic approach that obviously touches on the pillars of lifestyle medicine, but that ultimately makes sense to people. Yeah.
Thank
Can I
you,
just
Dr. Isioma. Yes, please.
Greg, I was just going to add, because our previous episode was about lifestyle medicine. And one of the things that we clearly stated was to meet the person where they are. And you've just clearly outlined that, Dr. Sioma. Thank you so much. It's about what is possible for that person. Those pillars of lifestyle medicine can be incorporated for somebody, but you have to meet them where they are. No point telling them go and join a gym when they don't have the time or the finances to do that.
And this is like a good moment to remind all of the participants that all of these episodes are available on our YouTube channel, youtube.com/@diabetesafrica. You'll be able to find tonight's episode as well as the previous episodes. We are now at the 4th season of Diabetes Health Matters. So there's plenty of content online if you'd like to learn more about diabetes and on a range of topics. And you can see on your screen also that the next episode, you can register. You can register now for the next episode. Just scan the QR code with your phone. We're going to take a couple more questions before we close this episode. And I also want to highlight that for the healthcare professionals who are in the UK and who would like to meet Dr. Joan St John and many of our experts, you can register your interest for our Diabetes Africa UK Forum that's going to take place in November. I see that there are more comments on the chat. Donna is saying very informative, thank you. And we've just shared the link to our YouTube channel. I'm going to go back to our questions. We'll take a couple more questions. Some of them were asked during registration. Are there any, Sandra is asking, are there natural solutions to menopause symptoms? But perhaps it's linked to what we just discussed about lifestyle medicine. But did you want to add to this, Dr. Isioma?
Yes, perhaps something we've not touched on as much is sleep. Because actually sleep disturbance is probably one of the earlier signs of perimenopause and menopause. Because we normalize bad sleep, people don't actually notice it. But sleep, as you know, people talk about sleep as a longevity hack, but you know, in terms of that vicious cycle of declining estrogen, increasing insulin resistance, metabolic change, stress, cortisol, poor sleep will add to that cycle. So figuring out ways to improve the quality of and quantity of your sleep, very important. I guess dovetailing to your question, natural remedies. You know, with regards to supplements that some people will use around this holistic approach to menopause care, magnesium is very helpful for sleep. We need to think about things like vitamin D, particularly in ethnic minority populations. And when I talk about, I guess, menopause treatment, so you have your more traditional hormone replacement treatment, and then you have your non-hormonal treatment, and within that, complementary medicine. The challenge we have is the evidence base for that is not as strong. So, and that's not a reason for people not to explore it. It just means you have to explore it with a complementary practitioner who has the expertise, and then make a decision for yourself. Some medications that are described with some evidence, but not strong enough compared to what we have, are things like black cohosh, St. John's wort, and plant estrogens, phytoestrogens. And again, as with any single drug, because these natural remedies are drugs, some of them have side effects and some of them have drug interactions. It's important to share with whichever health provider you're meeting what else you're on, so they can best advise you on if there's any interactions with these medications. But I guess the cliff notes are that the complementary options are, the evidence base is not as strong, and so it's not something that's routinely recommended by the NHS. However, you as an individual can explore your options. But again, thinking about supplements and again, sleep and diet and exercise in that holistic picture. And perhaps something we've not touched on, things such as cognitive behavioral therapy, talking therapy to help you manage your response to these symptoms as well.
Thank you, Dr. Isioma. That's a few very good points that we hadn't addressed yet. Dr. Joan, did you want to add?
No, I don't think I've got anything to add except that stay tuned. So come back next week and we'll explore some other options about things that we can do.
Thank you very much. Thank you. We're coming to the end of the episode, and I'd like to thank you very much, Dr. Isioma, for stepping in and answering the questions during this Q&A session, complementing the interview that we've ran at the beginning. Thank you so much for your insights, for your experience, for your generosity. And thank you, Dr. Joan, as well, for leading this discussion that we're going to continue next week.
So I would just say thanks to Diabetes Africa team, who has always very professionally produced this episode, this part of the webinar series, and looking forward to next week. I have to say a huge thank you to Dr. Isioma Okolo for standing in. Unfortunately, Dr. Itunu and Dr. Aziza weren't able to be with us this evening for the Q&A. We have had three phenomenal experts, Dr. Isioma, Dr. Aziza, Dr. Itunu, for these episodes, for these series on hormones and health. And we couldn't have asked for more. You have been phenomenal. You really have. Dr. Isioma is a global women's health advocate, an health equity advocate, a consultant obstetrician and gynecologist, a lecturer, a educator, and we are just so grateful to you. Thank you so much for answering all the questions and being with us this evening. Thank you to the participants, because we all learn together. Each one teach one, spread the word. Next week, we'll be talking more about this topic. So we look forward to seeing you then. And thanks one and all. Thank you.